Good evening to all of you, and I welcome you to this 110th session of the weekly huddle. It's been just about 2.5 years that we have been doing this, where we host hour-long program every Wednesday at 7 p.m. I'm your host Anoop, and hopefully joining me today will be my friend and co-host Praneeth. He is still finishing his angiogram. We both are cardiologists who recently joined Kim's Hospital. I'll just give a brief introduction of the huddle, which a lot of you already know about it. The huddle is an unscripted audience level interaction where we address common clinical scenarios that we encounter in our daily clinical practice. These days, we have been restricting our discussion around a clinical case, but the premise is that we discuss whatever is relevant to our clinical practice. So today, while we are not discussing a case, the topic that we're trying to discuss is something which is quite relevant, and it is, I would say, a pretty burning topic currently across the media and amongst the doctors as well. While we are not practicing infectious disease expert, this topic is of particular relevance to each one of us because we always have our friends, families, and friends and patients who ask us about our thought process, particularly with this emerging information about the new virus. So we are talking about the monkeypox virus, which very recently, I believe a few days ago, WHO declared it a global health emergency. Now, the fact that it has been found in, I believe, more than 70 countries now, with US and Europe pretty much leading the count. So we are going to try to discuss about the monkeypox virus, what it is, what kind of clinical syndrome it presents, are there any available treatment, what kind of virulence we can expect? Is it another COVID, which is going to come up like a wave? Is it going to affect a lot of us? What are the transmission patterns? Is there any concern for India? Now, the fact I believe that I don't know, maybe 5 or 6 cases have been confirmed yet, where the government of Telangana is already considering screening all international arrivals. I don't think that has been placed in rule yet. We should be discussing who are at risk population, what are the prevention strategies, are there any hygiene like what we have been talking about masking and stuff for COVID? Is there something like that for monkeypox? And what is the status of vaccination? So all of these things we will discuss, and obviously we don't know much about it. So we have got experts with us. Dr. Pratik Patil, he is an infectious disease expert at Kim's Hospital, Sikandrabad. He's going to be leading the discussion. And we will hopefully be joined by Dr. Shivaraju as well, who is also an expert in this particular field. When I say expert, because it's a new virus, I believe that a lot of us, we are also learning over the period of time. So, Pratik sir, typically we start this discussion with a clinical case, and we typically invite my cardiology colleagues to give their impression about the clinical case before we ask the expert for their opinion. In this particular session, because I don't have a clinical case, and I don't think a lot of us have a first-hand information about the monkeypox virus. So I will directly start with you. Maybe you can set the stage, and then we can engage in discussion. Just to give an idea, we have a variety of audience who participate in us. Maybe over time, we will see a few more people joining. The audience comprises of general physicians, medicine. We have got cardiologists from all across the spectrum. We'll have the junior most, we have the senior most. So we will get a variety of discussion on this platform. So Pratik sir, over the next few minutes, just give us a little bit of what you call narration on what this virus is, and then we can engage in discussion. Pratik sir, all yours.
Yep, sure. Thank you, Dr. Anoop. Thanks for this new thing what we are going to discuss today. See, if you see, like you mentioned, expert, but it's all probably a theory. Fortunately or unfortunately, most of us have not seen any case of monkeypox so far. But still, I would try to help you using some basic things about the infectious diseases so that we can have better preparedness and awareness about this disease. Probably, how are we going to tackle this? So, starting with this monkey virus, It's from the orthopox virus family. And the two other viruses which belong to the same family are the variola vaccine, which caused the smallpox, which probably most of us after 1980s have not seen any case. We just read it in the books that there was a disease like this. Probably we saw some of the senior people having the marks, permanent marks or scars following the smallpox. And then there is a vaccinia, the virus, which is used for the smallpox vaccine uh, preparation. So these three viruses are the part of this family. So now monkeypox is not a new disease. It's been known for many years. I think it was in 1970s that it was first reported, and it is mostly limited as a human disease in African countries, predominantly Central Africa and Western Africa. These are the two predominant clades, we can say, or strains, and it has caused quite a few occasions, some outbreaks. The disease had been limited to only these areas, and there were few outbreaks in US and Europe as well. But this is the first time there is such a global spread in the matter of 3 months. I think the current outbreak, which started in May 2022, already in matter of 3 months, it spread almost across all the continents where, except probably Antarctica. So, yeah, you have cases in North America, South America, Europe, Asia, uh, including the Australia, where and New Zealand, where they were quite strict about COVID, and but still they have more number of cases than in India. So in India, I think as of now we have four, as far as my knowledge goes. Three in Kerala, and I think sorry, four or five probably. No, two or three in Kerala, one in New Delhi, and one in I think Telangana. So these are the few cases that have been confirmed so far in India. So these outbreaks, the good thing, I'll talk about the clinical or the medical information subsequently. But good thing I'm going to say is probably the virus which is causing this is slightly different and probably more mutated for the human transmission, in terms of that's caused the probably less virulent strain. So it's the first thing we need to know is it's a less virulent strain than the conventional or the traditional strain. So the traditionally there is a mortality up to 11%. However, with the current epidemic which is going on, or the current outbreak, it's up to 6%. So 3 to 6% is the case fatality that has been reported so far. So that's in a way good thing. Now, second concern what we all have is whether it's going to be the next COVID. Uh, Fortunately or hopefully, it is not likely to be. Two reasons. Now, first thing, this is a virus which spreads by the droplet transmission. So that's why it's not like in COVID, which is airborne. Now we know, and initially also COVID, there was lot of confusion that whether it's airborne, whether it's a droplet. But now all of us know that it's an airborne disease. However, monkeypox we are dealing with for nearly 50 years. There is adequate information about the transmission dynamics so far. So we know it's a droplet infection. So the chances that somebody will get it through the air is very, very less. And the main concern should be the direct contact. So if somebody is having a lesions, then if you get in contact, that too a physical contact. So a short duration contact where you have not been involved in a physical touch, chances of transmission are very less. And again, uh, even through the droplets, it can happen, but again, it has to be a less than 6 feet distance. So these are the few favorable things. So a normal medical mask, which is a triple layer medical mask, which most often we use nowadays, should be good enough for you to protect from this virus, unless somebody is doing some aerosol generating procedures. Let's say somebody is intubated and you are going to do the suctioning on that, or some bronchoscopy. So for these kind of procedures, you need to wear N95, but otherwise the triple layer medical mask should be good enough to protect you from this disease, if at all there is some transmission through the air. So it should not happen more than 6 feet. It should be a very close contact for at least 15 minutes to have a significant exposure. So that is one thing epidemiologically we need to understand. So that's why it is less likely to spread rapidly. It's not as infectious as the smallpox. Smallpox was much more virulent and infectious. It is much lesser virulent than that. And then among the monkeypox, if you talk, there are two strains, and probably this is some third strain. So what we know is this second strain, which is common, and which is the third strain is derived from probably the second strain. It is less virulent than the first strain, which is the Congo or Central African strain. So the strain which is circulating across the world, it's less virulent than the first clade or the strain. So that's also a relatively good news, we can say. Yeah, I think this is what about the transmission dynamics. So it's about the contact. Most likely, yes. Now there is a case from Delhi which has been reported that he had not had any direct contact known, or he had not traveled. Now, rest of the cases had a history of travel from Middle East, and probably they had been exposed to the virus, probably they while they stay in the Middle East, or probably during the air travel. That's a possibility, because we all know that Middle East is a transit for most of us when you travel to the Europe or America. So there is a lot of mixing that happens in Middle East, or this thing. So that's possible, but there is one link in Delhi where there was no history of any travel, and that person has been confirmed to have a monkeypox. So that is the only odd situation. But I think so far the focus should be on travel history. So if somebody had traveled, probably we need to dig in more if they had been direct contact with anybody with skin rash. Now, if we talk about this disease process, or let's say the syndrome, now it's common that they have a fever. Now with just fever you may not be identified early, because usually the fever, infection, it has two different stages. One is the invasion stage, which is usually first 5 days, where the person may just have a fever, headache, which follows the lymph node enlargement, which is very significant finding. So probably when we see the patients on daily basis, probably now on, the another thing that we need to be careful is lymph nodes. So if somebody has a significant lymph node enlargement along with the other symptoms like back pain, muscle pain, asthenia, this can point towards possible monkeypox, and this is what separates or distinguishes it from the other fever with rash syndromes. Let's say the other close mimickers are herpes zoster, or the chicken pox, or the smallpox. So in obviously we don't see smallpox anymore, but in varicella and all, you don't see the lymph node enlargements, which is common in the monkeypox. So any patient, if somebody comes across with skin and rash, uh, which can be suspicious, always look for the lymph nodes. And if their lymph nodes, your suspicion should be really high that it can be monkeypox. And after the 3 days of fever only, most of the times the rash appears. So in first 3 days, this is the critical period. When there is a rash, probably you can identify it early, or you can initiate the process of testing and all. But in first 3 days, when there is no rash, that becomes critical period where we may get exposed, or many people might get exposed. That is what we need to focus on. If somebody has fever with recent transmission, recent travel from the anywhere, I would say right now, because as you mentioned already, that the hotspot is US and European countries like Spain, Portugal, UK. There are a lot of they have a lot of cases compared to other countries. So if they're all coming from these countries, we should be very suspicious after if they have fever. So we probably have to be double cautious in those cases.
Thank you, sir. We can probably ask few direct questions to you so that we can get a little bit of discussion around it. I was making notes as you were talking
Yep.
about. So few questions. As I look into all these media news, whatever comes, The only thing I see
Mm-hmm.
is the rash pattern. So my question to you is it a respiratory disease or is it a dermatologic disease or is it a systemic illness altogether?
It is a systemic disease. See, there should be a viremia. So there is a
Okay.
transient viremia initially when there is a febrile phase, first phase, there is a viremia and then it causes the rash. So the rash is not probably the transmission is local, but there is a phase of viremia, and that's how the dissemination in the body happens. So if you see the distribution of rash, the most common area involved is face. That's up to in I think around 90-95% of the cases, the face is involved, followed by the palms and soles, which is around 70-75, or mucosa is also involved in 70% cases nearly. So yes, it is both. It's there. So you can have the respiratory. So if somebody is coughing, probably you may still have to be careful. So that's why the mask is needed. So if it was just a locally or the just a contact transmission, probably you won't need a mask. But yes, there is a chance that you may get exposed due to the respiratory secretions because the lesions are seen outside, but you can have the lesions even in the oral mucosa. So through that, you can get exposed and you can get the viral infection. So that's why it's a droplet transmission, like I said. So you need to wear the mask and give the mask to the patient also if you have somebody suspected.
And you mentioned the mortality or the case fatality being 6 to 13%, earlier probably 13%. Now this is a mutated virus. So lower at 6%. I have two observations to that, and I'm going to ask you both of them. Number one, while 6% we are thinking it is better, it's still way high than what we were seeing in COVID. Other than Delta variant, the case fatality for COVID hardly touched 2% or so. So to me, a 6% case fatality for a monkeypox is very high. That is number one. And number two, how are they actually dying? Like, are they dying of respiratory illness or they are dying of some other problem? So if you could highlight both of them.
Yeah. So yes, the case fatality rate is 3 to 6%. Yes, it is probably higher than the COVID, and again, now with the time with the vaccine, the COVID case fatality has much improved. I would say it's not even 2% probably now, but initially probably it was around 4%, 2 to 4%, or probably sometimes around 6%. But now it's much lesser. So 3 to 6% is still high, but compared to the traditional thing, when you compare with the prior historical case fatality of monkeypox, this is less. So it's not really low, it is significant. Now, the causes of death are secondary bacterial infections. Obviously, these are pustules. So if you see the sequence of the disease progression, it starts with the initial febrile disease, followed by the skin eruptions, which progress from a macule, then become papules, becomes vesicle, pustules, and then crust. This is the natural progression of the skin lesions. Most often, it is a self-limited disease, which is 2 to 4 weeks. And the issue with this is now, this is probably slightly worse side of the story is when compared to the COVID, where as per understanding, the viral transmission period is around 8 days. But in this case, the viral transmission period is very high, a very long period. So you start probably spreading the virus or you're infectious from day to initial fever and onwards, or 1 or 2 days prior to the onset of rash, till your rash completely scabs and the crust formation, the crust falls off. So probably these people are infectious till the rash completely goes away. So you have a long infectious period here. That is the concern. So if exposed, you can expose to multiple people, and it has a long incubation period as well. So if you see, the incubation period is around 6 to 13 days, and which may vary again between 5 to 21 days, depends upon the host. So that is the concern here, that you may expose if identification is late, you may expose to multiple people. So now the causes of death. So it is known to have complications like secondary bacterial infections, pneumonia is known, sepsis is known, and encephalitis is also noted. These are the most commonest complications of this disease that have been reported so far.
Pratik sir, I have two more questions, but I think the stage is set for my attendees. If they have any questions, comments, or anything they want to add, please raise your hand or put your comments or question in the chat box so that we can keep the discussion going. Pratik sir, two things that come to my mind, which I will ask. Number one, you said droplet transmission. I I believe I read
Yeah.
that it is mostly happening in men who have sex with men. Is that correct? Like, is it an STD?
Yes. So there are two. No, no, no. It's not STD. See, there are two ways of transmission. One, like I said, droplet. Second is a contact, close contact. So it's a physical contact. So other than this respiratory droplet transmission, any contact with these rashes or the skin, ungloved. If you are not wearing gloves and if you touch or get exposed to the skin or the rashes or the body fluids of these people or patients, including the respiratory secretions, saliva, these are all infectious body fluids. So any such contact is possible exposure. That's one. So any physical contact is considered significant. So what you are mentioning is that the people who are uh, men having sex with men, MSMs, these are the commonest hosts to have these infections. However, we are not yet sure whether it's a sexually transmitted. Probably, obviously, during the sexual intercourse, there should be a close physical contact. That is the reason probably they have the such transmission, which is common. Again, probably it's the close physical contact. We still don't have enough data or information to say that it is spread through the sex. However, it is known to cause a vertical transmission. So from a pregnant mother, it can be transmitted to the fetus.
And sir, one last question before I open it for discussion. That is, where did I write that last question? How are we testing these viruses? Are we like PCR? What are we doing?
Yes. So again, the most important specimen is your vesicle or whatever the body fluid or the skin lesions. That lesion has to be sent. It can be the scraping, or it can be the fluid from the pustule or vesicle, or it could be the skin biopsy. That has to be sent for the PCR. And again, the difference from the COVID is there is no viral transmission media that is needed. So transport media. There is no transport media needed. It has to be a just in a sterile container. You can send it in a cold chain that is maintained. So there is no blood PCR here, and not even throat swab as per the current available guidelines. It's just the lesion that you have to send. Blood PCR is not accurate because the viremia is very short lasting. It's not a prolonged viremia. That's why it is inaccurate. So the only skin biopsy or the samples from the skin lesions are the diagnostic. And the antibodies or the antigen based tests are not good because they may have a cross reactivity. So as far as sampling or diagnosis is concerned, skin lesions, PCR from the skin lesions or the fluid.
And you said early in the days they don't get skin lesions. It mostly acts as a systemic illness with non-specific fever and cough. So how will we diagnose
That's
them?
right.
Like, how do we do
Yeah.
screening of asymptomatic carriers? Can we do that?
See, if you have somebody high risk host, let's say somebody who has been exposed to a case of monkeypox, and then he develops fever and these classic symptoms like body pain, asthenia, and lymph nodes. In that phase, probably we can send the blood PCR. We can do it because it's possibly this is a phase where there is a viremia. That's the reason probably they develop fever. But again, it's not foolproof. It's not widely available. The only place right now who is doing this is NIV Pune. So we have to isolate these people, probably get in touch with them, get the sample, and probably we can send it. They do it on special request, or as a special case, they will obviously try to do these things. But it's not been available as general guidelines so far because it's still probably we're evolving. We don't know what are the transmission dynamics so far. The people with history of MSMs, they were the high risk. But now we know that people who are traveling, that's risk. Now again, we don't know, like in case in Delhi where there is no travel history. So probably rash is the one most common, because rest of the times it can be any other disease. So to screen for everybody without history becomes very difficult, unless the number of cases rise too much so that we can suspect in every case. Like in current situation, if you see any mild respiratory disease or any sort of respiratory disease, the most common cause is COVID. But I don't think we can deal with the monkeypox same way at the moment, because our resources are limited. That's why we need to identify only the high risk cases or highly suspicious cases for this.
So if Telangana government or any other government, if they institute a policy of screening people who have come from abroad, how are they going to screen it? I'm just curious about it.
See, probably again they would ask the questionnaire whether somebody has been in contact with any person who had skin lesions or has been diagnosed with monkeypox. Okay, that's one. Any person who has a fever or any active lesions or skin rashes. So these are the few questions I can think of. They can ask, or they can screen for the fever or rashes. But I don't think there is any simple test to identify, and I don't think we can quarantine people just because they have come from abroad. Yes, high risk cases, they have to be under quarantine unless ruled otherwise. But I don't think it's easy to do that. But probably yes, we may have to start screening those people. At least even if you pick a few, that will be helpful. But we don't have any rapid multiplex PCR at the moment to screen everybody like what was done during the COVID. I don't think we have that much capability just yet.
Pratik sir, thank you for setting that stage. I will open the discussion and I'll start with Shankar sir for his comments or questions or anything. Shankar sir, please take over.
Good evening to all. The COVID, people have not fully recovered from COVID jolt, but monkeypox has entered into our country as a thunderbolt. So regarding Dr. Pratik has said, even in MSM may not be possible. It may be a personal contact because of face-to-face contact for more than 3 hours in the 2-meter radius. So prone for this monkeypox infection. So, but the virus is detected in the seminal and as well as the vaginal fluids also. So that's why the sexual transmission is also a possibility because of many cases detected to be having monkeypox, men with sex with the men only. So, and the second thing is the WHO, the World Health Organization, in post-recovery cases, it is insisting to use condom for 12 weeks during sexual activity. So, thinking that there may be possibility of sexual transmission between the partners. Regarding the transmission, apart from personal contact, direct, indirect, and all, respiratory droplet. And the second thing is the lymphadenopathy is a key distinguishing feature amongst the orthopox viruses, as Dr. Pratik Patil alluded to. But one more thing we see, especially smallpox, I have not seen, and unless there will be bioterrorism or biological war, the smallpox may enter into any arena. So smallpox in the chickenpox, that is a varicella, apart from the vesicular lesions are characteristically in a different stages of development and healing. So there may be macules, vesicles, then papules, pustules, scabs, and all. Different stages of these skin manifestations will be there in the chickenpox. But whereas in monkeypox, the skin lesions are of generally at the same stage. If they are vesicle stages, they are vesicles only. And one more thing is the umbilication will be there in the monkeypox, like similar to smallpox. And the skin lesions are more on the palms and soles in the face. This is typically seen in the smallpox, but not in the chickenpox. So likewise, the chickenpox can be differentiated because we come across chickenpox cases very frequently. This is regarding the varicella, differential diagnosis between varicella and the monkeypox or the chickenpox. And one more thing is, suppose we come across many viral illnesses with the prodromata, the same of monkeypox only, like myalgias, body ache, backache, then the fever, chills, sometimes adenopathy and all. But even after 5 days of this prodrome, if the patient does not get a rash, we can safely exclude that the patient is not having monkeypox, because the rash will appear at least within 2-3 days after the onset of the fever. So even after 5 days of prodrome, if the patient does not get a rash, we can safely rule out the monkeypox. These are my points so far.
Thank you so much, sir. I think that was quite relevant. I invite anybody who has got any questions or comments, either for Prateek sir or for Shankar sir. Either you can unmute yourself, ask the question, or write it in the chat box, and I will happily take it to the experts today. And while you do that, I will continue my discussion with Prateek sir regarding this particular virus. So, sir, one of the things that we did not discuss is vaccination. Now we hear this whole news about US men particularly lined up to get this vaccination done. Tell us about how are we getting this vaccine? How come monkeypox has a vaccine available, which COVID took 1.5 years to get? And what is this whole story about vaccine? Is it available? Is it working? Prateek sir.
Yeah. See, vaccine for COVID, the monkeypox is available, but only on certain criteria. So because it's been a disease which is there for nearly 50 years, so there are a couple of vaccines available. Just I think it's the one by Genios or something, and there is one more vaccine which is available, but it has been limited to the research setting. So those who have the lab workers or the people who handle the viruses in the lab for the research, these are the people who are traditionally vaccinated with these vaccines. However, CDC is vaccinating people nowadays who are at high risk, like immediate close contacts or the sexual partners who have been exposed. Between anybody who has had a close exposure up to 4 days, they are vaccinating, sometimes even up to 2 weeks. They are giving the vaccine for this. So the vaccines, this is a monkeypox vaccine. Regarding smallpox also, it gives some cross reactivity, so that people who had taken these smallpox vaccines, they will have some protection against the monkeypox. So this vaccine has been made available by CDC as a special recommendation for post-exposure prophylaxis. But I don't think that's available in India. So I think we have some problems there. But yes, since it's been a disease for a long time, it is available. Efficacy of these vaccines, I'm not sure how it is, but yeah, that's what I can say from my end regarding the vaccines.
Thank you, Prateek sir. I again reiterate, if anybody has got any questions or comments, please feel free to ask your questions. Or if you have a comment about your thoughts regarding this virus, you are welcome to unmute yourself and share your thought. And while you do that, I will continue my discussion with Prateek sir and Shankar sir. Please feel free to jump in whenever there is something that you want to add. So Pratik sir, we didn't talk about treatment part. Now we know it's a virus. So the antivirals, are we again going to start prescribing some weird antiviral for these drug for this virus? Do we have a standard therapy? What is the current status? Can we treat this virus?
See, most often it is the self-limiting disease, most often. So it may be, there are a couple of drugs which have been available by CDC. It was used for the smallpox, but supposed to work for monkeypox. So but we don't. I have never not heard that it is available in India. There is a drug called tecovirimat. Tecovirimat. Yeah, that's right. It is. So this is available, but not probably in India. US, it's available. The only thing, other options, as far as us we are concerned, cidofovir has been in vitro sensitive for these viruses, pox viruses. So that may be an option for us in cases who are sick. So that is only one thing that we can say. If somebody needs antiviral, probably CD4 is what we need. Cidofovir is what we need to consider.
Cidofovir is the same one that we use for hepatitis C. Is that correct?
No.
No.
Cidofovir was
No.
used for CMV.
For
CMV,
CMV. Okay.
cytomegalovirus.
For
Resistant
CMV, it was
CMV.
used.
It's reserved for the resistant CMV infections, which are resistant to probably ganciclovir or valganciclovir.
Okay, so it's a cidofovir, and that is available in India, is what you're saying.
Yes, we can make it
Okay.
available.
Okay, I see. I see. Sir, because we are all healthcare providers here, what is your suggestion in terms of going forward? Because seems like in this global world that we are living in, if there are 70 countries which have reported monkeypox, including India, and if it is something which is transmissible, it's just a matter of time before we start seeing these kind of cases in our clinics and hospitals. So is it time to react for healthcare workers because we are sitting in a higher risk setup? Or you think that right now we can wait and watch and see how things evolve?
I think
Sir,
we
you were,
have to be
yes.
and cautious about the cases. We should not be missing cases. That's the most important thing. And any rash that we handle, we have to be, cautious that we don't get ourselves exposed. And same time, we should report that so that the further chain of exposure is averted, and uh, we can take appropriate measures for isolation and reporting. So that is what I would say right now we have to do. We have to be very vigilant and then take it from there. Because we really don't know how is it going to spread, how many number of cases we are going to see, and regarding the severity also. So I think with time we will have more information. How is it spreading? Then we can take further notice, and with time, probably more number of labs will be available for testing, so that we can increase the screening process also.
Sir, one thing that we always talked about with COVID in terms of at-risk population for mortality, not for the infection, but for mortality. And what goes for every infection or every viral infection, which is elderly population, comorbidities, people who have got some concurrent illnesses, and all those which are obvious high-risk people who may not only get infected, but they have a higher risk of mortality. Is there some at-risk population described for monkeypox who are at high risk for mortality other than what I mentioned? Because I'm guessing, a weakened immunity, extremes of age, comorbidities, those are pretty standard. They sound generic, but they are pretty standard. I think that concept applies for every virus. But is there anything particular about this monkey virus?
Uh, I think it's like generic only. People with immune deficiency has been found to have worse outcomes. That's what the available information says. So probably the young kids and the people with immunodeficiency is what has been reported. And in pregnancy, because there is a vertical transmission, you can have a congenital monkeypox, or the lesions can be there in newborn. So these are the things are there, but nothing more particular about it as far as the information goes.
And I believe one of the things which we got it late in COVID was this role of building immune system in the form of eating healthy and taking vitamins and all those kind of things. And that actually triggered an entire cascade of prescribing heavy dose vitamins to those patients who were diagnosed COVID, thinking that it's going to help with their immune system, only to later realize that vitamins are something which we need over a general life, something that should strengthen our immune system rather than taking it at the time of illness. Will it be advisable that going forward, before we hit outbreak of monkeypox in India, is it advisable that we talk to our patients and tell them this is the time to build up your immunity either with healthy diet or with vitamin supplements or whatnot, so that if the wave comes, we are better prepared for that? Will that be an overkill, or you think that that is the correct way to go?
If you really frankly ask me, I don't suggest my patients about any vitamin supplements except probably vitamin D, because there is a common cause of hypovitaminous. I don't tested vitamin C in last week. I don't know how the tablet tests, frankly. So I don't support this. Yes, healthy diet is what I stick to, and I don't suggest blanket use of any vitamins or minerals or any supplements. If you have a vitamin D deficiency, probably you can take that, not for building up immunity. See, we think possibly there is some data that vitamin D may have something to do with lot of infection. There are some not very concrete data about COVID, but most of vitamin D makes sense. Once last, at least in sepsis, initially it was thought that in sick cases it helps, but it harms. That's what we know. Vitamin C overdoses harm the patients. So there is no data that vitamin C really helps. On the contrary, there are theories. What we saw a bad mucor case, overload after the second wave of, or even after first wave of COVID, and probably there is no confirmation yet, but zinc, which was used like crazy during the first and second wave, or probably even now it's been used by some of the people, has been associated with the infection. Like an iron or risk of mucormycosis. So similar possibly that triggered such an epidemic of mucor cases, we are not sure, but that could be a contributory factor. So I would not recommend any diet, any additional supplements except for a normal healthy food, is what my take on this.
So, sir, if you say that vitamin C or that Limcy tablet did not help, then all these people who popped it in kilos, not just in milligrams, they will feel really bad about it.
I can tell you, that's okay. There is no evidence, so why I should support it? That's fine. It's okay. You made a mistake, but the important thing is to learn. Now, yes, initially when there is no data, probably that's fine to take a chance. But now we are 2 years down the line, we are much more wiser. There is a lot more data. So why do it now? If you're making the same mistake, even after knowing things, then it's worse.
Thank you, Pratik, sir. Any questions or comments amongst the attendees? I will ask Somaraju sir for his opinion about today's topic, and if he can share his thoughts about monkeypox virus as a general. Sir, I'm sure you must have seen smallpox in your days. Somaraju sir.
Thank you, Anoop. Good evening to everybody. Interesting thing about this disease is that nothing to declare except my ignorance. about absolute ignorance about the disease. And I heard a lot of few of you speaking about it. My only suggestion is for a period of time, what we went through in COVID-19, from ignorance to slowly acquiring significant knowledge about it, and we are slightly more aware of the disease than what we started with. Let us not commit the same mistake in this disease, taking things for granted. And a lot of expert opinions based upon incomplete information or guesswork, and that includes even WHO. Be careful about all this. And also last day I wanted to comment, so much is being talked about rash. Be aware of colored races, including Asians. Rash is a problem to detect early in disease. Thank you.
Sir, your comments on the public health point of view, because it is, I believe it is just a matter of time before we see a lot of these cases in our area. As far as the public health policies are concerned, you are in a position with all your years of experience where I think you can share your insights, how we as a doctor or public policy maker should be preparing for this. So at least from the doctor's standpoint, you can tell us how we should be preparing for this wave coming forward, both for our protection.
Yeah, thank you, Anoop. We can only be aware of the fundamental fact, as Rodolphe Virchow said in mid-19th century, and now we know that social determinants of health, medicine is a social science, and medicine is a political science today. And where we live and your overcrowding and all other issues, those social determinants will influence any disease that we come across. And now we know the fundamental truth about COVID is as long as Chinese don't change their dietary habits, COVID is not going to disappear. I have no idea about this disease, and I can only share my ignorance. Thank you.
Thank you so much, sir. I think that public determinants of health is something that we have brought into our discussion multiple times so far. And I really wanted to do a huddle session on this to understand our roles in the so-called defining the public determinants, understanding that we are not in an authority position or what you call the leadership position. But still, I think that from our individual point of view, we can discuss and do something like that. Maybe in the future, I'll bring this up. Shankar sir, anything last point to add before I close today's session?
So far, for the monkeypox, because it belongs to the orthopox viruses, so the smallpox vaccines, which are available in US and UK, that is Jynneos in USA, Imvanex in Europe, and Immune in Canada. They are available. They give cross immunity to monkeypox, but they are meant for smallpox. But since smallpox is eradicated in 1977, so we have not been, the vaccine is discontinued literally, but still the smallpox vaccines are available in the said countries, and modified vaccinia Ankara, that is the MVA vaccine, so far what I have alluded to, that is given 2 doses with 4 weeks apart. So and second, one more vaccine is there, that is also for the smallpox, which gives a cross immunity to the monkeypox, ACAM 2000 vaccine. These 2 vaccines are there at present. They are being used in many countries in the global outbreak, and specific agents for the though it is a mild disease, but sometimes it may be severe enough, because if it occurs in less than 8 years child or pregnant or breastfeeding mothers, or patients with complications of infections like sepsis, encephalitis, bronchopneumonia and all. So in immunocompromised patients, those HIV patients, those who are with lymphoma, generalized malignancy, organ transplantation, bone marrow transplants, chemotherapy, cytotoxic agents, radiation, TNF-alpha inhibitors. So these patients, they will have immunocompromised status, so that there the monkeypox will be very severe enough. So in those patients, we can give. So in mild cases, it is a self-limiting disease. In mild cases, there is only supportive therapy. But in these severe forms, these agents are also meant for only smallpox, but they can be used here. So repurposeful, but they are found to be active, effective. Tecovirimat, and one more is, as Dr. Pratik Patel told, cidofovir or brincidofovir. They can be given alone or they can be given combined, and oral and intravenous preparations are also available. They can be given for 14 days. There is one more vaccina, immune globulin is also available in advanced countries. So it may be considered in immune suppressed individuals with the exposure history, so that we can avoid occurrence of the disease. So these are the regarding the specific agents for the disease and specific pox vaccines. So they are not available in India, but see, we developed Covaxin within a year. So in no time the outbreak goes on. These agents will be made available in a short period. Thank you, one and all.
Thank you, Shankar sir. Pratik sir, any closing last minute thoughts about this before I close the session?
No, I think we should be vigilant is what I would say. Probably just keep eyes closed, eyes open, and keep your thought process in line to see any case with probable history and rash. You should be able to differentiate early with the points we discussed, so that early reporting and further spread is averted. So that's what I would say, and then let's see how it goes.
Perfect. Thank you so much, sir. Thank you all for attending today's session. Special thanks to Pratik sir for enlightening us with his insights about this new virus. To all the attendees who are particularly joining us for the first time, we would like to get your feedback for the session. And if you find the session worthwhile, you may share it with your colleagues. As I mentioned previously, the weekly huddle we host it every Wednesday. So the same link that you used to join today will be working for future sessions as well. And all our weekly huddle sessions are recorded, and eventually they are available on podcast and YouTube platforms after a delay of a month or two. So if you want to listen to some of the previous recorded sessions, you can always go back and use your dead time to listen to some of the discussion that we had previously. If nobody has any other comments or questions, then I would like to close the session for today. Thank you, Pratik sir, again, and thank you all of you. Good night. We will see you again next Wednesday.
Good night. Bye.